today here, and we are really happy to organize one more edition of our Be Future Ready program with this. May I invite Dr. Chandrima Paul, President of the Kolkata Association of Ophthalmologists, to deliver the welcome address, please.
Good morning, everybody, and thank you, Dr. Shurajit. So, a very warm welcome to each one of you here this morning to spare your Sunday morning to take forward our second episode of Be Future Ready, which is on refractive surgery. Before I go any further, could I please request you to rise for a minute of silence in memory of Professor Ranavir Mukherjee, who is actually who was the chief patron and actually the architect of the Kolkata Association of Ophthalmologists. Thank you very much. You may take your seats. We have a very important announcement this morning. That is, we've opened postgraduate trainee memberships to the Kolkata Association of Ophthalmologists. So you can become members with all rights and privileges of the normal life members, except you cannot vote, you cannot contest an election or take up any executive body post. So apart from that, you will get all the rights and privileges of a life member if you become members of the Kolkata Association of Ophthalmologists. And we're opening it today. So we have our treasurer with us, Dr. Shoma Ghosh Kundu. She's sitting there. So you can approach her for your memberships. She has the forms and everything with her. So you can become members, and this is at a very subsidized rate because it's starting. That's just 1,000 rupees for the postgraduate trainees. But of course, you need to give a certification from your institute saying that you are a postgraduate trainee. And the other thing is that we have a membership drive, and this is probably the last month for that drive, where we have a subsidized rate for life membership of 2,000 rupees. That's for the month of October. From November, probably it will go back to the normal rate of 5,000 rupees. So thank you very much once again for being here this morning. I take privilege in introducing our legendary chairpersons, Dr. Pradeep Kumar Bakshi, who's the pioneer of LASIK in Eastern India, and we have him here with us this morning to enlighten the session. With him we have Dr. Pushpita Shahu, nonetheless in the field of ophthalmology, and Dr. Kajol Prasad Ghosh, who's been a pioneer of many things in Eastern India, and of course our very own Dr. Divyesh Shah, who's an excellent hand in LASIK, and we see him every other day operating in our theaters, and he's, let me tell you, to say the least, that he's spectacular, absolutely spectacular. Thank you very much for being here today. And the master of ceremonies, the moderator this morning, is none other than our very own Dr. Shubhranshu Sengupta, who is a very dynamic and a very promising, excellent surgeon himself at both LASIK and phaco. Over to you, Shubhranshu, for the proceedings. Thank you very much.
Thank you for those kind words. So without any further ado, we move on to the main program. The panelists for the day are Dr. Suparna Sinha, Dr. Surya Gupta, Dr. Tuhin Chaudhary, and we will be shortly joined by Dr. Arnav Mitra, Dr. Keshav Haldar, and Dr. Nandini Chandak. So now moving on to the first talk of the day, choice of LASIK, will be delivered by none other than Dr. Divyesh P. Shah. Dr. Shah did his graduation from RG Kar Medical College and his post-graduation from Ahmedabad. He is actually one of the first to start phaco in Eastern India, PRK and LASIK way back in 1998-99. Sir is the proprietor of Sri Netra Eye Foundation, and he is a site-first technical advisor for East and South India for Lion Hospitals. Over to you, sir.
Good morning, friends. And thank you, KAO, Chundrima, and office bearers for having me here. It's a big honor. And Shubhrangshu for beautifully introducing me. Thank you so much. LASIK is a passion, and it's always a pleasure to talk about LASIK. There's a long history, starting from 98, 99, and we have seen all the days which have when the LASIK advanced step by step. So you can make it interactive if Chundrima and the chairperson allows. Ask me any questions in between if you want to ask, or we can have it later also. So I always begin with this great man's picture, who first thought that we can change the corneal curvature to change the power of the eye. And after that, a lot of things have come and gone. We are still aiming for utopia when patient will not have any problem and that we can give the best corrected vision to the patient. So the path has been very convoluted, we have faced a lots of ups and downs, and we are still, I can say that we are still looking for absolute utopia. We had lots of difficulties. We started with very basic keratomes, faced a lots of problems, seen free flaps, partial flaps, and whatnot. Luckily now, we have now absolutely the top class microkeratome available with us. And last few years, I think last almost 10 years, touch wood, we haven't had any problem with as far as the flap making is concerned. Diagnostics have gone from absolutely nowhere to absolutely to the top. We have best machines, including topolizer and pentacam, which gives us a lot of information about the patient's cornea, aberrations, and everything. And it is much easier to say no to a patient now, that it's better not to take chances with your cornea. We are not very sure about what's going to happen after LASIK, after a few years. So diagnostics have become very good, with especially, I must mention, with Bellin-Ambrosio. It's better to say no if there is any red flag there. So the results have improved. Again, touch wood, last more than 10 years, I personally, after doing how many thousands of LASIK, we haven't seen any ectasia so far. Again, I'm saying it's God's grace. But we must give due credit to the advancement of science. Pulse frequency, Dr. Bakshi is here, he is the doyen. He will bear with me. From large pulse diameters to beam lasers, now we have come down to very small pulses of excimer laser, 0.9 millimeter, which has really changed. The ablations of the surface is very smooth. The frequency has gone very fast, so the treatment time has gone down like anything. Initially, we used to take almost a minute to do about -3 to -4 diopters of surgery. Now it's just a blink of eyelid. Doesn't take time. So initially, when I started with EX500, I used to be amazed. No, coming from that machine to this machine, it's so good. So what happens is, patients are also very comfortable, and the results are also very good. Dehydration doesn't happen. If you take longer with ablation, dehydration takes place. So that changes the parameters again. So recovery of the vision is also very good. And there are other factors also which have been now optimized in the machine. Like initially I'll come down as I go on with my slides, it will come. So the speed, as I said, it has really made a difference. And the visual recovery is also so fast, so quick. Now, this is also important. As the pulses are distributed in such a way, the heating up just doesn't happen. And previously we used to have, fans. The heating used to happen, the plume used to happen, it used to settle down. All these things have gone. Machines were also very sensitive to heat at that time, or even the odor. It used to change the characteristics of the pulses or the laser. It doesn't happen anymore. It is so stable. So now we have peripheral control. The pulses are given in such a way that even the peripheral part of the cornea gets optimally ablated. Previously, there was a problem. So patients used to have visual problems like ghost images or starbursts and all those things. Now it is much less. It started when the aspheric parameters were introduced in Bausch and Lomb LASIK. And then it has improved from there on. Eye tracker system again has improved like anything. It's much quicker, and a little movement is caught very quickly, and the cornea is ablated in that way. So the main advantage of the present day machines and algorithms and the software is that the corneal shape to a large extent is maintained. If there is any change in the corneal shape, as used to happen before, the acuity maybe used to come, but the sharpness, contrast, all those logma, if we used to check at that time the logmar chart also with the patient's eyes, what used to happen. So now all these things have improved. Night vision has improved. So a little bit about the asphericity of the cornea. So as we maintain the normal asphericity of the cornea, as we are able to maintain now to a large extent, the peripheral vision, the night vision problems, all those problems, the ghost images, they have all reduced like anything. Nowadays, hardly any patient complains about evening shadows or halos or glare. It's a fact. Previously, we used to tell very particularly to the patient that you are going to face this, especially when the diopters to be corrected rose from 2. Patients were bound to have halos and glares and all those things, especially in the evening night vision problem. But now, I say just for the sake of it, but hardly any patient comes back and tells me that I'm having any driving problem in the evening or night, unless the diopters to be corrected is high. I think my colleagues will bear with me. If anybody has seen anything else, please tell me. This is my own experience. So any change in the corneal shape used to happen, the higher order ablations, the halos, shadows, starburst, all these things used to come in, which is no more. So as we advanced, we started with wavefront guided LASIK, wavefront optimized LASIK. We started to customize the LASIK to the patient's eyes. The diagnostic equipments became better and better, so we were able to customize the eyes. So we were talking about personalized laser vision correction, which has now improved a lot. So now we are mostly doing topo-guided LASIK. Topo-guided LASIK means we are taking into account the shape of the cornea, little ups, little downs. It is not very accurate. It is not absolutely smooth. There are aberrations. All these things are taken into account when we are taking the proper topography reading of the cornea. So what happens is, it measures 22,000 points on the cornea. That's huge, and that makes a lot of difference. So any imperfection or irregularity which gives rise to the higher order aberrations like more commas or more trefoils, tetrafoils, all those things. They are taken into account and corrected with the laser. Another advantage of this topographic, this so-called, now we call it, it's called Contura, which is basically a name given by the company which manufactures this LASIK machine. But Contura has become very popular because of these points. Nowadays, even 3-4 years, people were not very aware about Contura, but now patients come asking for Contura. I am very surprised. That's because of the fantastic result it gives. The main advantage being, sorry, it takes into account the visual axis of the eye, not the pupillary center. It corrects the corneal surface irregularities. The difference is, when we do wavefront guided LASIK, what it does is, it takes into account all the aberrations of the eye, which can change. At a particular period of time, a patient may have a different level of tear layer on the cornea, different type of dilatation, different crystalline lens. All these things are a very changing thing. It doesn't remain the same. So that is the main drawback of wavefront guided LASIK. Here, what is happening is only the corneal surface is taken into account. So the results are very accurate. Most of the patients end up with more than 6/6 vision. It also tracks the cyclorotation, which I think very few machines track. Cyclorotation is a fact, and it is tracked by this machine. So here you see the surface of the cornea after topo-guided LASIK, which is much more similar to the normal. So as I said, wavefront takes into account all elements of optical system of the eye, and it gets changed by wound healing, ablation predictability, and all those things. There is one more method called topo-guided LASIK, wavefront optimized laser, which corrects the spherical aberration only, but rest of the things remain uncorrected or same. So Contura or topo-guided ablation induces much less higher order aberration, improves corneal sphericity compared to the other ones. It corrects coma, trefoil, etc. That's the higher order aberrations which are there on the corneal surface. Tissue ablation is much less. Previously, we used to ablate around 16 micron per diopter. Now it has come down to almost 12 micron per diopter. And future touch-ups, because more cornea is remaining after the correction, so future touch-ups, if required, are easier. So this is the change we have seen on the corneal surface and the corneal contour. And this is a small comparison with the other way of doing refractive surgery. Contura, the advantage of Contura vision is, I'm speaking on Contura because it's my favorite. And I have seen it gives fantastic results. The visual recovery is much faster, contrast sensitivity is much better, and scatter index is much less. Again, it's because the way it is programmed. Most of the patients end up getting more than 6/6, as I said. More or less more than 90% patients get 6/5, and some of the patients, almost 33% patients end up with 6/4. It's a common occurrence. Better night vision, it gives better contrast and superior vision quality. Next is now, last few years, surface ablations are also getting popular, although I'm not a big fan of surface ablations, but quite a few of my colleagues are doing surface ablations regularly. But what I miss with surface ablation is that wow factor. And patients do have some problems after the surgery, and we have to keep counseling the patients. So I am not a fan of surface ablations. I have colleagues who can speak about these modalities. And finally, the last thing, the most in thing, relax, smile. A lot of people are talking about it. Quite a few people are doing it and vouching by its advantages. For myself, I will say that I'm yet to be convinced by the advantages of Relax Smile, coming from my own experience of doing LASIK for so many years. And most of the advantages or disadvantages of LASIK, like ectasia or dryness, which are tom-tom, for me, I'm hardly seeing. Very few people, out of few thousands, I have seen so far, again, by the grace of God, only 2 ectasias in my life. After doing only 2. Maybe some other have gone to some other colleagues of mine, I haven't seen them. But still, it's a very, very low percentage. Very, very low percentage. And the science says, the data say, that ectasia following smile is around 0.15, and ectasia following LASIK surgery is around 0.2. 0.15 and 0.2. Almost the same. But again, there will be pluses, there will be minuses. People will talk a lot about one thing. But it has definitely been observed that there are no major disadvantages or advantages of one over the other. And from my practice, I'm still continuing with my Contour Vision, which I'm doing very regularly. I have already spoken about these points, the advantages of Contour Vision over the other surgeries. So thank you very much for your attention, and thank you again for giving me this opportunity.
Thank you, sir, for sharing your vast experience with us. Now, we are going to take a few questions. So, to begin with, may I start with the panelists? When we are planning a LASIK, what are the parameters that you look at? Which situations are there when you say that no, LASIK should not be taken up for you? We'll start with the panelists and then summarizing by sir.
I'm not doing LASIK for the last 10 years. Last LASIK I have done was, I think, 10, 12 years back. So I just do a routine screening in my clinic, and then I refer it to a surgeon. So my basic screening will be power should be stable for a year, and the age should be, I follow more than 21, and the patient should not have very overt dry eye symptoms. And rest I refer to the surgeon who will be doing, and for him or her to evaluate regarding the topo changes and all.
Dr. Nandini?
Like sir already said, obviously 18 years is what I follow as a cutoff. Above 18 years, if the refraction has been stable for more than 6 months, is when we see the patient can be ideal candidate for LASIK. What I personally follow is the patient should be motivated himself. Instead of telling the patient, because it's a refractive surgery, once the patients ask for them, it's more easier to convince them about LASIK. Corneal thickness, yes, that has to be seen. Plus the Bellin's embryo map, that really has to be checked before we go ahead for LASIK, which I'm sure sir has already mentioned about, and that's some things which we have to consider before we think about LASIK.
And so what are the residual stromal bed cutoffs that you look at?
280 micron. And then that percentage ablation should be more than 40%. Should be less than 40%.
Sorry, come again.
But altered.
Should be?
PTA. The percentage altered. That should be less than 40%.
Percent tissue altered is the flap thickness plus the ablated area divided by the whole cornea into 100.
Yes.
Is the PTA. So that should not cross 40%. It's a rough thing, but you should tend to avoid crossing 40%.
And do any of us look at post-op K-max values when we are counseling a patient?
Of course.
Post-op, I mean, pre-op, obviously we are looking at the topo map, and what post-op values will get to K-max values?
During planning of the operation, we have to calculate how much the K value is going to change. 34 to 48 is the limits. Should not go down below 34 or more than 48 to avoid the aberrations.
How much tissue ablation?
Tissue ablation here. Tissue ablation,
Not,
there are four
not
factors.
more than 100 micron.
Oh,
Preferably.
yeah. The tissue ablation is 20%. Yeah, better not to exceed 100. But yes, if the cornea is sufficiently thick, 110, 115, 20 people also do. Other thing is that optic zone. Optic zone is the pupil. I'll just come with the discussion. I mean, I think in my presentation it will be covered. Don't worry.
So may I just request sir to summarize what basic pre-op checks we must do before saying yes to a patient, basic ones. Advanced ones will deal, Dr. Shudip will deal.
I don't know the difference between basic and advanced, but whatever I do, I'll say. Number one, if the patient is having, apart from routinely examining the eye and retina and everything, it should be very thorough checkup, lacrimal system, or tear layer, all those things need to be checked up. If the patient has dry eye, better treat the dry eyes first before taking up the patient for LASIK. If the patient has treatable problems in the retina, should be taken up first. And what we do is, if we are doing barrage laser, we do it at least 15 days after the barrage laser. If the patient is taking any tablet, any kind of medicines, hormonal treatments, or if the patient is having any collagen vascular diseases or immunodeficiency problems, those are absolute no-no. Then coming to the diagnostic part, sorry. Now, Pentacam is a fantastic tool. So we absolutely look at Bellin Ambrosio. If possible, we should also look at the higher order aberrations, and then if possible compare it with the corneal topolizer, so that we can actually decide which will be better for the patient. Then we must, as already discussed, as Ayan was telling me, it is a thing of past, but 20 years or even 15 years back, we have treated a large number of patients having -15, -16, -17, even -18, even +10, +11. Those days we were young, we like to take risks. But all those patients are still coming back to me without having any ectasia. We used to, at that time, our benchmark was 250 microns should be left.
Even FDA today, the approved thickness is 250 by FDA.
Yeah. Now we leave behind 300. We don't like to go below that. But none of those high myop patients who have been treated have developed ectasia. I don't know, it's my luck. So corneal tensile strength is something which hasn't been proved very well so far. That is something altogether different. Killer has come out with a machine which checks that strength, but practically it hasn't come in the market so that we can actually test the patient's eye with that and then decide whether we should go ahead with LASIK or not. One thing I'll always say, as I have gained in experience and gained a lot of gray hairs now, any little thing which tells me that I should not do LASIK on this patient, I will avoid. Just avoid. So more or less in my practice, what I have seen is at least one patient gets rejected out of 5 if the other parameters are normal, and still there is so much of rejection. As Nandini said, I will never push a patient for LASIK. But luckily now, last few years, patients are coming themselves for LASIK. That is a big change in the market. Somehow, we have seen the days when there were no LASIKs. Now patients come themselves. So market is improving, expanding, and there is a lot of scope. I think that's what it should.
Divesh, can I ask you something? This session is for comprehensive ophthalmologists, right? And one of the most important things you said was to treat dry eyes. Could you please elaborate on that?
I think somebody is already speaking on dry eyes. See, basically what we do is tear meniscus, T-butt, and Schirmer's. And if the patient has... Sorry?
Do you routinely do Schirmer's test?
I routinely do Schirmer. I routinely see
You
T-butt.
recommend Schirmer's test for everybody before you do the surgery?
All patients, specifically when the patient comes for refractive surgery.
So, ma'am will be...
No, as I already said, that very thorough examination means it includes the condition of the leads and adnexa.
Ma'am will be taking up this topic. Dr. Oyon will be speaking on it in details.
I'd just like to ask the house, the panelist or Divesh, what are the studies? It's because I'm a referring doctor. So what are the studies that show the stability of a power after 18 years of age? If I refer a patient at 18 years of age and that patient has a power change, I do get patients who do have power changes at 20, 21, 22. So how would I be able to explain it to the patient?
Not possible. So,
Are there studies?
No. It is very different.
Or it's just anecdotal?
No. What, as Nandini said, my criterion is no change in power for 1 year.
But that can also change. They can come back.
Usually it doesn't. After that,
are there studies to back me
Oyon
up?
has some more to add.
There are no studies to prove that the power has stabilized, but one thing I tell my patients routinely if they are keen on doing LASIK at the age of 18, that there might be a change in power for which you need to go for a retreatment. That's what I tell every patient who is coming at the age of 18 for LASIK, because there are some course to get admitted, like
absolutely
most of the courses, the Merchant Navy and all, they require a emmetropia 6x6 without glasses while entering the course. So
the thing that we keep telling our patients power will stabilize at 22, power will stabilize at 20.
No, you cannot say that.
There must be some studies there.
I don't think so, because I have seen power changing even at the age of 30, 32.
Yes, but what is the percentage? There must be a bell
very
curve,
low.
There must be
very
something.
low, but even then it changes. Because sometimes I find patients who have advised LASIK 5 years back, at that time the power has changed at least 15 to 20% from that time to
how
today.
many patients in 1,000, say, from your experience?
So maybe 150.
150 out of 1,000.
See, if patient comes at 18, 19 years age, even 20, 21 years age, and after that he has not gone for LASIK, and I'm seeing again at the age of 27, there is at least a change in power by 10 to 15%. Because most of the patients coming up with post-LASIK regressions are not actually regressions.
I agree fully. I don't know, somehow in my practice I haven't seen such a large percentage of patients. More or less after 21, 22 the power stabilizes in a big way. Usually.
I do have patients who have come, and this is not quite a significant number of patients who have undergone LASIK and have come back, and they have -1 power, -2 power. They are
as Oyon said, most of it is not regression. Regression is very low.
It's not regression. It's because
most
it
of
was
it is
done
not
too
regression.
early. So it was
that's
done
why
too early.
that is the reason I keep 1 year.
And any of us, we are doing cycloplegic refraction just to recheck?
I always do.
Routinely. Yeah. Because there is some amount of pseudomyopia also sometimes here.
Yes.
And one more point I would like to mention is, I usually avoid LASIK in patients with epithelial basement membrane dystrophies. In those patients, if you do LASIK, there is a chance of recurrent corneal erosion. So it's better to go for PRK if the number is less.
Yeah, true.
Very difficult, sir,
No,
because
sir.
Out of say around around 15 to 20,000 eyes we operated till now, maybe more. Only one patient had ectasia, and we followed everything that was required before going for LASIK. Every parameter was normal, including corneal thickness. There was no abnormal topographical signs or symptoms, signs of the patient or any kind of eye rubbing or history of allergy or nothing was there. But there was ectasia. We could not explain why.
No, it is unexplainable. That is why we are waiting for that something like that killer. You must have seen the machine.
And
Corneal hysteresis is a very known as well as unknown thing.
Biomechanical strength.
Biomechanical strength, absolutely.
One more thing is I also operated on a patient that too, it was basically advocated by Dr. Babu Rajendran, he's no more, but he used to say that don't go for LASIK, go for
PRK.
trans-PRK. It was his favorite technique.
He was a big fan of
trans-PRK.
Yeah.
Trans-PRK means epithelium and stromal ablation at a single go.
Yes.
And even I operated patients with about -12 to -13 diopters, trans-PRK, without any problem.
Metabolite, anti-metabolite?
Yes, of course, mitomycin C, yes.
So he started this, and he was a big proponent of this method. After going to his clinic and seeing a few cases, I also started doing some. I did a few trans-PRK.
There were 4 to 5 cases of solid corneal, central corneal scar, which I had a tough time. I had sleepless nights to remove them and bring back to normal.
Yeah. My problem was patients complaining, I could not take it. LASIK has absolutely, touch wood. The next day the patient comes with such a broad smile. So I don't want to do anything else. That is my drawback, if you say so.
That smile is not there in smile, I think.
Devesh, can you tell me something about epi-LASIK, which was here done by Dr. Palikaris? He involved epi-LASIK, but he was the father of LASIK, no doubt. But then he found certain places, certain cases where there was thin corneas. He would do LASIK on them, but it was epi-LASIK. Do you have any idea what it is?
Sir, we have done some very small numbers when Elegant that time, or AMO, at that time it was Elegant only. They had come out here to Kolkata with that machine, and we tried on a few cases. APK. So
but we
it's
didn't
good.
Have that. We didn't
it's
have
good.
that machine.
Sorry?
We didn't have that machine.
No, we tried it on a few patients.
Whatever
because
we did was PRK.
Yeah, ultimately we came down to LASIK only. But I think PRK is quite good, surface ablation. We don't need to do anything else. If you cannot do LASIK and if PRK is possible, go for PRK.
And
surface ablation has come back in a big way, but not AP-LASIK.
And also there is Streamlight PRK, if you want to highlight about that.
Sorry?
Streamlight PRK.
You talk about it.
No, it's not my talk.
I don't do it.
So we wind up the first topic.
Thank you very much.
Thank you, Dr. Shah. It was wonderful listening to you and all the lively discussion. So now we'll go on to planning and customizing your LASIK procedure. Dr. Shudip Chaudhary will be delivering the talk. Dr. Chaudhary started LASIK in Kolkata way back in 1998. He performed LASIK in the first LASIK center of Guwahati from 2003 to 2013. He helped to set up the first LASIK surgery setup at Aizawl in Mizoram. He operated there for about 5 years and more importantly, trained the local surgeons. He is attached to Better Sight Center, Kolkata for LASIK till 2021, and presently he is attached to BBI Foundation, Kolkata. His favorite hobbies include trekking in the Himalayas and watercolor. He recently held a watercolor exhibition at Academy of Fine Arts just a year ago, and he's also published a book, My Watercolor Diaries, which was just published about a month ago. Over to you, Dr. Chaudhary.
Good morning, all of you, my seniors, my colleagues. Thank you. I'm very grateful to the organizers who extended this opportunity to me to talk about this part of the LASIK procedure. We begin straight away. I think we can go slowly. If any confusion and if any clarification is required, just we can stop. So, forward contact. So the primary aim of LASIK surgery today is not to increase the visual acuity in bright light, but also in the dim light. Yes, I'm talking about the contrast, I'm talking about the glares, halos, apart from a bright light visual acuity. Just a brief, Dr. Shah has already explained, only 2 simple steps. Lifting up a flap, we have an option of a microkeratome or a femtosecond laser, and then shaping of the surface of the cornea. So presently, the available laser machines are wavefront optimized, or a topo-guided or contour, or wavefront guided. I have to explain a little bit briefly, in a little bit details about a few things about the visual axis, the centration during LASIK surgery, and about the aberrations. These 2 are possibly the pillars on which the LASIK stands. When you see an eye from outside, a simple thing, you just look at the iris, and this is the pupil. We are actually not seeing the iris, we are seeing the image of the iris. So the center of the iris, the center of the pupil is not a fixed thing. It keeps changing. If the shape of the pupil changes, the center will shift. But if you calculate from the limbus, the center of the limbus is somewhat stable. This pentacam, these laser machines during centration take care of this part. Briefly about the axis. When we see a thing, supposing the fixation point is here, this is the visual axis. It straight meets at the fovea. And here, the center of the pupil, it's over here. But when we tell the patients to do the scanning, the pentacam, oculizer and all, the corneal apex is this part. This is the corneal apex that is taken as a 0 coordinate, like an x and y graph, this is 0, 0. So that means from there, they gave an estimate of the decentration of the pupil. It's called the pupil offsets. So they give a special coordinate for the pupil offset and a special coordinate for the cornea vertex, where we get the first Purkinje image. The line of sight or visual axis is somewhere between this pupil offset value and this corneal vertex value. So this is important in centration. Centration, the laser is locked at the pupillary center. After getting locked, the laser tracks the movement of the cyclotorsion, X and Y movement, but the laser actually fires in the center somewhere here close to the corneal vertex. And if the angle kappa is big, angle kappa is this one, ideally we should focus it somewhere between this pupil value and the corneal vertex value. Corneal apex is a 0, 0 coordinate, vertex is slightly nasal, so they are not the same. Now again coming back to the topolizer, you see we have blown up this thing just to show that this is the placidodic, this is the corneal apex and this is the pupil center. There is a shift. So in a hyperope or a high astigmatism, the shift may be more. Then the laser centration should be done between these 2. I'll come to that a little later. Now, basic aberration. This is the basic thing. I mean, just give me a little time to explain it. Only one line. Light travels with a different speed in different medium. That covers everything up. This is a straight wavefront, all the particles in the same phase. This is the air, suppose, this is the cornea. So in this line, this particle from here to here travels fast, it's in air, whereas this particle from here to here travels slow. It takes up after getting the necessary changes here also, so you get this wavefront changes, it aligns itself to the front surface. Then again here, when it comes out in the aqueous faster, it moves fast, whereas this part moves slow. It takes up a curvature like this. So this is called a positive spherical aberration. So this is all about aberrations. Aberration, if you follow this part of the curve, it has a concavity. It focuses, this focus earlier. This is diverging. It focuses behind. So there is a difference of focus. This is the spherical aberration, positive. Other way around will be a negative spherical aberration. Now, what has actually done is, in a wavefront guided kind of thing, we measure these aberrations, and if we pick up on one wavefront layer out here, normally it should have been smooth and just like that. But in reality, it is a little bit shallow here, raised here, different sort of curvatures. The idea is to change this into this. Aberration is important only in over pupil size is more than 4 millimeter. Beyond 4 millimeter, it sets in. 5 and 6 and 7, it's much more. Lower order aberrations are only because of the refractive errors, plus minus power and astigmatism. Only the change of the shape is lower order. But if you blow it up further, the secondary waveforms, the irregularity, those are the higher order aberration. So among the aberrations, so there are many things. Most important is defocus, trefoil, comma. So it's not that aberration is bad. It gives us a sense of depth. Comma helps us to see better for the near. But yes, in sometimes the light spread, the contrast goes down, glare and halos is much more. So an attempt is made just to reduce as much as possible. One more time, if we visit this, supposing this flat wavefronts, these are getting refracted, they change the shape according to the front surface of the cornea, of the lens. Here I've just drawn a lens here. And then when this part from here comes out, it moves faster. Here it is slow because this particle is still inside the cornea. This is faster. So it comes out like this. It comes out like this. This is a negative spherical aberration. The bulge is towards the left. And supposing the opposite side the light comes, it's the same waveform. Direction is changed, but the pattern remains same. What wavefront guided does is, it picks up a wavefront, analyzes it. How do they do that? They fit it against the best fit sphere or a best fit ellipsoid. This time I just went to best fit sphere maybe. And compared to the sphere, the elevated part is designed as red, the depressed part is blue. It creates a map of the wavefront. Important is, the data here is only very much pupil dependent. As much as the pupil allows the wavefront to come out and be measured, it moves. So this is another type. So supposing a cornea like this. So here movement is fast, here movement is slow. This pattern picks up the pattern of the front surface. Now when it comes out, this again has to travel less. It comes out and bulges out. This has to travel more in the cornea. The shape is like this, again a positive spherical aberration. Lens somewhat compresses the corneal aberrations. And ultimately the thing we get, that is the final one, that is transferred into a map. That map has to be printed on the cornea with a differential cutting after aligning the eye with the tracker so that eye doesn't move here and there, the laser also moves. So the topo-guided, what it does topo-guided, that was the previous one was wavefront guided. This topo-guided, what it does is, it just measures the irregularity of the cornea. It doesn't measure the aberration directly, only the irregularity. And here, the data can be taken throughout the cornea, not only the central part as it was before. It makes a map. So this map, combined with the pentacam data, this full thing can be absolutely accurately transferred here, provided this is done under tracking. Why tracking? Because if the eye moves, they will lose their position. So, and here, one more adjustment is required. I'm coming out later with this is called a Q adjustment. So, coming one more time, I'll discuss my things, basically what I went through. Nowadays, because we are doing femtosecond, it's very important to rule out any corneal scars or minimum of opacities. These are the potential weak areas, and this can break open. The vertical breakthrough can happen. The air bubble is in high pressure. Yes, I operated one patient with nuclear sclerosis long time back, 20 years back. Someone else screened it. I operated only to find out the next day that there was a substantial nuclear sclerosis. So before we do it, because I did it, that's why I just won a little bit of, because just to check out a minimum of nuclear sclerosis. And yes, I could detect 3 or 4 Marfan syndrome with significant zonular dialysis. So better because we are seeing a skewed population, very high power and all. So better to dilate fully and check the zonule, and always pre-treat the dry eye. And this I have explained before. Now a little bit above the topo map. How do we read it? Suppose this is a curve. We measure the curve again a best fit sphere. Accordingly, the high zones are in red, the shallow zones are in blue. So now I straight away come to the pentacam. Now this is a power map. So this is power is symmetric astigmatism. With the rule, you put 180 degree minus something axis. So this is the power, and this is the actual mountain one, the actual size. Why the power is there? Because the mountain has steep slopes going down. It's getting shallow very fast. The slope is out here. The power is so high here. So this is the elevation map, and this is the power map. And now, how to go to basically rule out the basic things. We start with একটা পোর্শন কেটে গেছে ওদিকে ওই পাশের ভ্যালুসগুলো Okay, I come to this map. So we start with a Q quality check. The QS quality specification should be okay, then the map is okay. Then we straight come to Q value. I use Q more often because I'm used to it. Q is, this is a prolet shift, minus 0.3. The more it's minus, more prolet. And Q more than 1 is an oblate shift. So here we have a steep axis and the flat axis, a steep and a flat. And the astigmatism, the values are here, and the astigmatism is 1.1 here and 0.4 here. Here it is advisable to check the refraction against these values. Ideally they say combine them. Minus 1.8 plus 0.4 is minus 0.7, and see whether the patient is accepting either minus 1 or minus 0.7 or the clinical astigmatism, and give accordingly we can adjust. Now, straight away I come back to the previous one. Here, we look at this. I usually go to the pupil center and check the coordinates. This gives an impression of angle kappa. If it is more than 0.2 millimeter, the angle kappa may be on the higher side. Then we can, because before we start to interpret these two maps, we need an angle kappa. Angle kappa, if it is high, then these two maps can be skewed, a little bit skewed. It is not entirely in the axis, so it gives an abnormal shape. And these are the elevation map, front and back. Please look at the central values. They should be less than 12 or 15. So, and this is compared against a best fit sphere, BFS, best fit sphere. So apart from angle kappa, then we have to go to the pachyapex. You see the coordinate values are 0, 0, and it is shown by a point over here. The thinnest local is very important. Thinnest local, if it is more than 1, especially inferiorly directed, inferior to the pachyapex, then we may be looking at a little abnormal map. There is no specific, there's no sharp division between a keratoconus and a normal. There is a fudge. So there is a gradual transition. Better to go for a normal map or an abnormal map. And this is the Q1 I was talking about, more Q high in minus values, it is more prolate. And this is a circle, Q is 0. Oblate is after a myopic ablation. Center is oblate, this is flat. And what is the importance of this Q value is? Q value is very important because this, suppose normally the cornea is slightly prolate. So they get an they get focused somewhere here together. Now when we make the central portion flat, the peripheral portion power increases and it focuses in front. That is called a positive spherical aberration. That means even if we correct the refraction, the patient won't be happy. The power is gone, but the peripheral rays are creating problems. They are not focused at the same point. So what is to be done is we have to reduce the curvature at the periphery so that all rays get at a single focus. Now coming back to here again, so this is the next step what we go for. Okay, now from here we do two things. We see what is the thinnest local. So accordingly we can measure how much power we can remove. Best thing is just keep as much of corneal tissue possible behind. Doesn't matter what we do. Ablation, they say 20%, 100. Yes, I have gone 120. As Dr. Shah told, we even worked deeper in the previous machines. Anyhow, presently 100 to 120 microns, 20%. The flap is 90 to 100 microns. We try to go for 90 microns flap. And this ablation maximum, whatever we can do, should be 20% of the thinnest local. And the residual stroma should be normally 250, 280, these are standard teachings, but I try to keep more than 300. And this is important, the pupil zone is very important. The pupil zone, the pupil diameter, supposing we are going to change the shape, we are going to make it flat. This is also flat, this is also flat. But the zone is big, so depth is more. So zone is small, depth is less. So please, we have to see that it doesn't cut too much of tissue. But the best idea is to keep the pupil zone as much as possible. 6.5 millimeter is possible. But there is a fine balance. There's a balance between the residual stroma, pupil zone, power, everything. And now the back calculation I was talking about. Before the operation, I have to get an idea how much the power is, the K value is going to change. Suppose we work with this refraction. For 1 diopter change, 0.75 diopter change at the corneal level. So for a cylindrical, 3.5 means 3.5 into 0.75 is 2.6. So 2.6 straight away subtract from the high value. So that becomes 42.4. Now we have 42.4 here, 42 here. Now we take on the spherical. 7 into 0.75 is 5.25. Subtract that from both these values. We end up with this, which is favorable. We can predict, we can proceed. And similarly, if a plus power is there, the value is 1.2, not 0.75. So the change is more at the corneal level. Suppose we tackle this refraction, it's a 1.5. That means the shallow one, it has gotten cut off here, it should be 42 here, and that was 45 something, 44 something. So 42, the shallow one, 1.5 means the change in the value over here will be 1.5 into 1.2 is 3. You add up, this becomes more steep. 42 becomes 45, and then you tackle this one. Plus 4 into 1.2 is 4.8. Add both to this meridian, this meridian. This goes beyond 48 or 49. So that means it's a bit on the higher side. So we have to adjust. We have to go down. So basically the power correction is a fine balance between these 4 things. Residual stromal bed, maximum ablation, zone of treatment, and limits of K value. So again, coming back, quick checklist. So this value, this is the anterior, posterior elevation value. Everything is normal. This is a with the rule astigmatism. Thinnest local, everything is normal. This chord did not a significant angle kappa. And then we check inside whether we get any high values. This is not. So that means we can proceed. Now another advanced chart is a Bellin's. We just check out this corneal thickness, spatial profile, and PTI. This red line should not go below. The average is given here, and these 2 maps should be in a green zone. So that means, and this is absolutely okay. This is in the green zone, means yes, we can proceed. This is an advanced map. There are some other ratios, variations, values are given there just to rule out keratoconus and grade them. So now, for another person, now straight away reading a map, so we go to the Q value first. It's cut off, but I think it is a bit on the higher side, 0.3. So this is a steep cornea, slightly skewed, but still within 22. Here you see the values are more than 12, 13, 14, something like that. So just to, how do we know that this is not abnormal? So we change this. Instead of a best fit sphere, we go, it's the same map, we are going for a best fit toric ellipsoid. And this is gone. This is absolutely normal now. And here, the thinnest local, these values are within range. So, and in this case, when we go for the Bellin's, typically we see this small yellow zones, a borderline changes sometimes. Patients are wearing contact lens, dry eye, they present like this. So in this case, if everything is otherwise normal, we repeat this test. If it is still coming yellow, yes, still maybe we can keep a little more cushion than usual. But if the power is absolutely okay, I think I will proceed. And here the Q is 0.8. It's not shown here, it is getting cut off, but it is 0.8. It's a very steep prolate cornea. And you see the values are high, 14, 12, 32, 23. We expected some sort of inferior decentration of this thinnest local. It's not there. This is normal. Kappa is normal. So again, this shows a typical keratoconus, anterior and posterior cone. This is dropping before the 6 millimeter. So basically these things are also in red flags. So basically it is a keratoconus patient. Now coming back to the axis one more time, just for a quick revision. This is important because patient is looking, if we tell the patient to look here, the patient looks here. So myopic patient, fovea is here. Hyperopic patient, the eye will be small. So fovea will be somewhere here. If the hyperopic patient tries to align with that fixed point, he has to spin the eye in a clockwise direction. The fovea has to come here. The axis is open up. Open up means between the corneal vertex, the pupil, the gap increases. So if we look in a myopic and a normal patient, see this is the corneal vertex, the Purkinje image, the white one. The green one is where the laser locks at the pupil center. But the visual axis is somewhere between these two. But yes, this is almost the same. We can straight away fire on the corneal vertex. But here, in a hyperopia, battery my one is working. In a hyperopia, the pupil is somewhere here, the vertex is here, the visual axis will be somewhere here. all these lasers are programmed to lock at the pupil. Automatically the laser shifts to the corneal vertex and fires, taking this as a center. That means there may be a little decentration in this case if we go with a normal laser thing. So we have to shift it somewhere between the two. There are certain values, 50%, 75%. So better to go for a 50% decentration from this value. 50% from this and not on the vertex. So this is all in the machine. So once it's adjusted, I think we get a beautiful decentration and the accurate decentration. These type of things are lacking in the smile. The exact, specific, absolutely coordinate, absolute under control, these fine things yet to be developed. So basically that was talking about the decentration part. Now why LASIK? Because it has almost a wide range of correction. Minus 0.5 plus minus 4-5 cylinder to minus 10, 11 if the cornea permits. Reasonably accurate laser centration. You have a perfect active tracking. Iris recognition, eye spins, the laser spins, pupil center tracking, tracking X, Y, and cyclotorsion. Ablation, Dr. Shah discussed the ablation profile optimized, thermal controls there. Basically by a wavefront optimized or this wavefront guided and a contour, we get a map. The map can be absolutely printed on the cornea with a differential cutting at the same proportions using the axis tracking. It locks at the pupil center and it recognizes the iris. It's cyclotorsion tracking. If the eye normally spins to 5 to 10 degrees, this tracking can also be done. So it is absolutely perfect. So we can play the video. Yeah. Okay, etai din. Agettai kore dewa jabe. Agettai eta. So in a femtosecond, acha thik hai, play kora jabe eta. In a femtosecond cut, I'll just after lifting up the flap, I'll just show it here. So the machine shows it is started to track. So this shows the bed thickness is 404 something. So there are some controls. It has started to track, and once it starts to track, it will register the cyclorotation here. Here, it is registering a 5 degree cyclorotation. The X and Y coordinates are ready. The laser is firing. It's locked at the pupil center, but actually the laser is firing a little nasally with the center. So, and this is this is showing a dynamic process, how the corneal thickness is changing. We do not end up accidentally ablating more. So ultimately, parameters of a good visual outcome is a refraction, the aberration, perfect laser delivery, and minimum ablation. One more quick look. This wavefront changes. This is the final wavefront. So ideally, it should be a very smooth one. It is something like this. This has a concavity, means it focuses earlier. This has a bit of a divergence, means focuses behind. So machine detects if it is here, so that means you have to make it a little bit flatter because the power is more, it is getting focused. This is a little bit hyperopic laser. It has to be a little bit steeper. Combination of cutting out here so that the focus is absolutely focus on the retina. So, and this is the wavefront optimized. The fat parallel, this thing, this wavefront, this is the slight deviation of the wavefront, a positive spherical aberration. So what it does is it just a little bit of shaping over here at the periphery so that it gets a simple focus. This is called a Q adjustment. So that was the important of that Q value. Q value after operation can change. So patient is used to one Q value. Better to keep the Q value in that range. And this is the contour, how it works. It only measures the corneal irregularity. In that process, it also reduces aberrations. Differential cutting under tracking, after scanning 22,000 points, we have to adjust the Q value, and under a tracker, the whole thing operates. Here, the full cornea can be treated. Little irregularity at the center, like TCAT and all, can also be treated. And over 40 years of age, yes, we have to consider a little bit of undercorrection. We have to talk to the patient whether he will be happy with the full correction or the slight undercorrection, what a 1 eye for distance, 1 eye for near. Here, one small thing, because of the age factor, I always prefer microkeratome over a femtosecond flap because of the age factor. And topo-guided, wavefront-guided, we have already discussed. The most important points, what we go for is corneal data. This topo-guided is corneal data, pupil independent. It doesn't matter what the pupil, small or big, the corneal data are perfect. We get the full corneal values of the data. Treatment automatically shifts to visual axis. Combination of hyperopic and myopic profiles give laser ablation, whereas a wavefront guided will give a little bit deeper ablation. It doesn't give us more information from the periphery of the cornea. And one more thing about this LASIK and SMILE. So LASIK is over here. We just lift up the flap, do the ablation, and under a tracker, the whole ablation is controlled. Here it forms air bubbles. The machine cannot see, the machine cannot track, machine cannot register cyclotorsion, and little bit astigmatic. The axis presentation is also a little bit of a problem over here. It has a bit of a manual adjustment required in LASIK and in SMILE. Last thing is I would prefer LASIK always, because over SMILE, few factors are there. SMILE has a restricted range of power. Too small power, too thin lenticule, we can fragment it while taking it out. Cuts more tissue than LASIK to remove the same power. Suppose we operate -4. Here we correct at loss 50, 60 micron. It may be a touch more than that in SMILE. Proper centration on vertex is a little bit patient dependent. Patient has to fix, and also a little bit of adjustment, manual adjustment needs to be done. Alignment on astigmatic axis is little bit, maybe a little bit not absolutely accurate as in LASIK, because of an iris recognition, interop tracking is not there. And one more thing is there. This is the SMILE flap. After taking off this lenticule, when the flap is collapsed, it cannot expand equally in all directions. It's closed here. A little bit of aberration can seep in. And the complications, I believe that it's almost the same, because here the flap, it's an indirect flap only. We are not lifting up the flap. The last thing is, in femtosecond flap you have used, we always use a pocket. We always use a pocket of around half of the corneal thickness deep, when it starts with the pocket. In SMILE, I also believe they have some pocketing outside. Extra cuts are there. So basically, end of the day, I've come to the conclusion mostly. So basically, choosing a patient, this customizing, each and every step is a customization. So that's why I had to discuss so many things. So a little bit of variation. This is so precise, so perfect, the delivery. So basically nowadays, Dr. Shah will be knowing, we don't think about 6.6 or 6.5 anymore, I think. So even a microkeratome, I believe, gives a superb result. Microkeratome is indeed very good. Yes, femtosecond has the advantage of a robotics. But ultimately what I feel is taking the skill away from the surgeon and giving it to the machine. And end of the day, yes, but we are maybe become, end of the day, a lot more machine dependent. Here one more time, the plain LASIK will have this tracking much more. All this thing, everything is under control, and starting from this centration and the laser, things are absolutely precise and accurate. Next slide. I think I have talked more than enough. I mean, please, I'm sorry I have eaten up a lot of time. Please, go ahead.
No, it was wonderful listening to such a difficult topic being tackled so lucidly and so fluidly. Thank you, sir. And the last was your painting, sir, the one that you showed on the thank you slide. Just a small example of what. So such a nice topics covered so vastly. So we'll throw open the questions. Anyone with any questions?
Please. Yeah.
So
yeah, please.
May I ask?
Yeah.
So basically, like you mentioned, 40 plus.
Yeah, 40 plus we have to adjust because of we have to talk to the patient.
Why microkeratome over femto?
Oh, yeah. Femtosecond, femto flap. It takes around 30 seconds to cut a flap. Machine says 17 seconds is the actual cut, but the process of raising the suction, docking it, and then adjusting and all, taking off the suction, all thing takes around 25 to 30 seconds. That means we are, yeah. Because nowadays I focus both ways. I lift up the bed, I put down it just to decrease the time. Of this. Otherwise, if we keep the bed fixed and bring it down, it takes more time. So both ways. So and that way we can gradually try to reduce the time, but still it is not possible to do it less than 25 seconds. Whereas in a microkeratome, 10 seconds, 10 seconds, 10 seconds. 10 to 11 seconds, it can be done. So basically that thing is there. That means we impede and the pressurize is more, because in femtosecond the cornea is already under pressure when we press it. So pressurize is more, so basically better because I operated on what they call it, when 70 years of age patient came, and operated also 60 years of age patient. He got a high power difference. I operated with a LASIK. That time I was young. I thought I will be absolutely okay. The patient ended up with a 50% visual field loss after this microkeratome procedure. That was 15, 16 years back. Then I decided, no, after 40, 50, better to scale down the pressure part of it, not to take any chance.
One more thing I would like to add, because
yeah.
You said timing for the suction to happen and the procedure to be complete. Femto takes much more time, and it leads to more goblet cell injury than blade keratome.
Yeah, basically, because blade keratome is fast. You just put the suction as run the machine, 10 seconds, 12 seconds. But in a case of a femto, the time goes up. So now it's a robotics. People want to purchase, people want to go into robotics. I think that done safely, LASIK with a microkeratome, yes, femto also gives a superb result. Absolutely, you don't have to think about it.
So when we picked up the topic of IOP rise, so what is the experience of the house with respect to hard dock and soft dock as far as femto is concerned?
Oh yeah, in SMILE less thing. SMILE actually the thing is less.
Even some machines have soft dock for femto.
Yeah, this curvature part, instead of a flat thing, they have curvature and all thing. That may be better, but the duration, where will you hide it?
And in that particular case, the visual field loss, you
that
feel
was a
IOP rise.
And what happened is, normally after taking the patient, telling the patient to get up from the bed, I always make them count the finger, always, because it's a legal thing. Because suddenly you don't know, one can have a stroke or a occlusion, something. So that patient, after after getting up from the bed for 3 minutes, couldn't see properly. Whereas in LASIK patients, immediately they start seeing. So there must be something in the aged people. So that is why, yes, the machines are always there. The company will always be pushing those things. But as a doctor, it's our responsibility to safeguard our interest and also the patient's interest.
Any comments from the chairpersons? Sorry, we have.
Normally, sir, in microkeratome, 60 millimeter, when we used to measure it early, it was 60 millimeter at the starting point. But see, sir, it was initially 60. Now, when the microkeratome moves over it, it compresses it. Pressure should go up more. Not measured, or even if measured, it doesn't come out. In femto also it's high, so basically a little bit on the, better to finish it as fast as possible. That's the thing.
Yeah, it flattens the cornea in the process.
Because normally it is 60, then femto also. Normally raised to 30-40, okay, patient seeing not much. But when it is 30-40, then you flatten the full cornea. You imagine the impact on the angles and the anterior segment.
Dr. Shudeep, there's a quick question.
Yeah, please.
I would like to have your opinion about, any message for the referring surgeon, who to send for femto, who to send for a regular microkeratome LASIK, and again, when...
most of us do femto and micro both.
Yeah.
I was very lucky to run a microkeratome over all sorts of patients in Guwahati, in Mizoram, and they gave me RK patients, radial keratotomy patients, post-cataract patients.
What about
even I did around 15 to 16 years, 20 eyes in Guwahati. Then Dr. Arundhati went and presented it in Europe for a pediatric LASIK.
So would you have any word of advice for the general ophthalmologist who would be a referral surgeon for you? What kind of patients to refer, because we need to know when to sort of keep the contact lenses off for how long.
If the patient is motivated, if the age is more than 18, 19, power is more or less stable, no other significant problem is there, I think we can go ahead with LASIK. Absolutely, no problem in it. Absolutely.
Even with a mild dry eye? Or
As I told you, dry eye has to be pre-treated. That has to be. Otherwise the data error will be there. In Contura, Pentacam, all the data errors will be there. So for the precision, for the safety, I think it's a pre-treatment.
And how long ago would you want the patient to stop using contact lenses or something?
At least the soft contact lens, 7 days minimum, if not more, if possible, because the element of a dry eye, beyond the pressure part, there's an element of a dry eye also. And the semi-soft contact lens, maybe a couple of weeks, and we have to check out about the dryness.
Thank you.
Also the warpage, because the semi-soft lens is called
change
warpage.
of the cornea, And the cornea thickens, a long-standing corneal patient wearing contact lens, they claim that oxygen permeates, but not that much, and the thickness of the cornea can go up a little bit. So better to...
Yeah, even the tear film is very...
everything is unstable, so better to, if possible, to have 7-10 days time.
Sudeep, one question for you. You have an extensive experience of doing LASIK. Did you ever encounter a free flap? Or do you make the markers on every
I'll tell
case?
you a story, sir. I'll tell you a story. Give me 5 minutes. Dr. Jyotika Pal is not there. Okay. Madam sent a patient in Mizoram, 2001 or 2, something like that. The patient was from Mizoram. Dr. Jyotika Pal referred. I normally mark the cornea with a single mark and an asymmetric mark, so that even the flap gets turned away if something happens, so we align it. So that day that marker was not there. I didn't mark. I proceeded. Ended up in a free flap. Now, I just set it there. It was sitting perfectly. I put a contact lens. The patient went back. Next day he came. It slided off. the flap was lost in the inferior fornix somewhere, and I had to retrieve the contact lens, search for the flap. I took out the flap, no marking. I just blessed it out again, stitched it. He came back after 2 more days. She went to Jyotika Pal. She told, okay, she must be okay. Then next day she came back. I had some doubt. I just put a little bit of fluorescein. It went in. I know that it is sitting upside down. I had to take out then stitches one more time. I took that patient to BBI Foundation. The stitches were taken off. Again, it has to be, I have to clean by that time, after 3-4 days, the epithelium keeps growing in. So I have to scrape off from both the surface and then put the flap again, put the stitch again. Then again, after 7 days or 10 days, I took off the stitches. It took 15-20 days for the patient to see properly, and it was on 25th December. I still remember the date. Patient came back on the 1st of January something. He told that, yes, I'm having a good vision after 25th. On 25th, I started to see. Dr. Jyotika Pal, me, and Dr. Parthuda was also there. We all looked. There was absolutely crystal clear. Vision was 6/9. That time, I knew that these Mizo people are really cool and calm. Otherwise, I would have bended in a lot of a problem.
I will tell my experience. I have not done as many cases as you have. But when I started in 1997,
yes, sir.
And then about in 2000, 2002, till then I was doing LASIK. In my initial phases, I was happy. But suddenly one day, as you said, we didn't have, and those days, in late 90s, we didn't have those markers as yet in our place in Better Sight, if you remember. And suddenly one day I had a free flap.
No, I was always telling
I had a free flap, and then I didn't know which one is up and which one is down.
Exactly. So
that is the most difficult part.
Yes, sir. Nowadays,
so I met
those old microkeratomes, you cannot make out which one is the top and which one is the bottom. Nowadays, you can make out. This is one rough surface.
It was unfortunate for you. You had the epithelium underneath and the stroma upper. But lucky for me, the next day when he came, it was stuck. The fluorescein stain went onto the cornea and the edges, but didn't go in. So I was sure that it had come. But unfortunately, what happened, because we had not done any marking or anything to oppose, he had a very high astigmatism. And then Partho and me got that astigmatism corrected to maximum extent. He had 6/9 vision at the end of the day. But it was a dreadful night.
Absolutely, sir.
Absolutely, I didn't know whether I put it right or wrong. So marker is a must.
Absolutely.
For, I think, if you're a beginner,
it's just
or if you are
climbing the mountain without a rope. Basically, what I feel after getting 7 or 8 in difficult situations, any such problem, it's a difficult thing that happens. Yes.
So going back to the referral surgeon for LASIK, you all are LASIK surgeons. I'm not a LASIK surgeon. I'm a referral surgeon for LASIK. So I want to know. Actually, I have a very unique story. I had a couple of patients, 2 sisters, who underwent LASIK. One of them underwent LASIK, femto-LASIK with Contura, and the other underwent SMILE. The one with femto-LASIK with Contura was over the moon, that I'm seeing very well. I'm seeing 6/4, as Divesh had said, and But the one who had done SMILE was very unhappy, saying, I always see halos, I cannot drive at night now, I'm having a lot of problems. So me being a referral surgeon, it's very difficult for me to deal with these things. So would you just explain for because most of us here are referral surgeons, we are not LASIK surgeons.
No, madam.
How should you explain, and what are the advantages of femto-LASIK with Contura over SMILE?
See, LASIK, femto-LASIK with the Contura is absolutely precise, computer-controlled thing. You don't have to do anything. You just lift up the flap and just center the laser, and if required, we decenter. Important is we fire it on the visual axis, adjust for angle kappa, and give a wider zone so that there is no significant aberrations or there's glares and contrast. So zone is a problem in this SMILE. Number 2 is the alignment of the axis. The astigmatic axis is a bit of a thing. Then centration is a problem with SMILE because it has to be a manual one. And number 4 is when the flap falls back after LASIK, it equally spreads in all direction, leaving no tissue. I mean, it's an absolute beautiful apposition, but in a smile, the flap of it cannot expand. The central island, the central lenticule is taken off. So if it collapses, it cannot expand on the sides. A little bit of irregularity can creep in. So all these factors may be a combination, but I still believe LASIK, if LASIK was not this safe, I could have, definitely we would have choices, but now considering we have this LASIK, I think it's a safer choice.
So is there any way that we can treat these aberrations which the girl is having from SMILE?
Sorry, madam?
Can we treat these aberrations which the girl is having from SMILE?
It's very difficult to detect what is the cause, whether it is the zone, whether it is the optical axis alignment, the axis misalignment, or the irregularity. Irregular part can be taken off in the contoura, PRK, those sort of thing. But I don't think it is possible to send a patient for operation again and again, and it will be a difficult thing. Better to adjust, better to use medicines and get used to it and wait more time for more time. Basically,
your thoughts, Dr. Divesh, on that?
Yes.
I was thinking that, yes, topography guided lasers are basically meant for correcting these kinds of aberrations.
Absolutely.
Only thing is, we have to look at the corneal flap more, how much thinner we can take. Sometimes PRK also helps, PRK with contoura.
PRK helps very much.
Yes.
Believe me, last 25 years, I have never used a mitomycin. Never used mitomycin last 25 years. I have not done more than -5 diopters power. I have done around 30, 40, and I still distinctly remember one patient undergoing PRK, one eye LASIK. He is very happy with the PRK, more than LASIK.
So all the corneal abnormalities, most of them can be corrected with topography guided.
Absolutely, and along with that, the power can be taken care of.
So what I understand, and for the message of the house, that the Contoura vision technology is much superior to SMILE as far as it tracks each point and it gives you a guided...
I believe so, and I would love to believe so, because the precision is too much. Everything is developed 10, 15 years back. Now what we are seeing is all this were done 15 years back. SMILE is also not a new thing. Always, it's roughly long back it has been there. But still, because of the control is much more in LASIK. That much, I think.
Thank you. Thank you.
And one more point I would like to mention is in SMILE, you have to dissect the lenticule out. One dissection below the lenticule, the other one above the lenticule with a mechanical, in a mechanical manner.
A lot of manipulation.
And that way you are inducing a lot of tissue damage at the microscopic level, which causes quite a good amount of stromal edema the next day.
Blunt dissection that can damage the edges. Femtosecond laser, what does it do to the edges? What effect, what collateral damage you have? See, all the data we won't ever get. They're kept below the mat.
It has been seen that backscatter,
and the
higher order aberrations,
and the thing is
more with SMILE. But I think SMILE is still a work in progress, maybe after a couple of years.
Okay.
And with the silk coming in,
second. Oyon,
please.
I'm not a LASIK surgeon, but I'm studying it. Whatever my knowledge goes, the corneal clarity is dependent on the lattice arrangement of the corneal stroma.
Right, sir.
Yeah. So, don't you think that with this SMILE, whatever you do, taking up the flap, you are doing it with femto. It's a very absolutely precise. But whenever you take the flap out, you are taking the advantage of the spatula. Is it not going to damage the lattice arrangement of the cornea?
Yes, sir. That's what I told. I mean, it's going to damage and it's going to quite a good amount of stromal edema the very next day. So that wow factor that is there in Contoura vision LASIK is not there in SMILE.
Basically, sir, we are, I mean, just to keep things simple, LASIK is the most simple thing. The beauty of LASIK is it in simplicity. Everybody can do it. Very simple. And
even I agree with Sudeep, blade LASIK is more precise than femtosecond LASIK. Because
I still believe that microkeratome is a wonderful option we have. FemtoLASIK, because now a new generation, they want all these robots and all those things. We have to...
Sudeep.
Yeah.
Sudeep, one question.
Yes, sir.
Now in LASIK, have you seen epithelial ingrowths in LASIK
lot of
compared to smile procedure where you take out the lenticle?
LASIK we have seen ingrowths. I have also seen with a microkeratome, not with a femto as of now. Ingrowth that can be easily managed, lift up the thing and just scrape off from the below the thing. But lifting up the flap in femto, I don't know how much pressure you have to give, how much dissection you have to make to go in. And those are the things that additions may be little more in femto, but this only people can.
To flap, you can make the edge beveled. So the chances of epithelial ingrowth is much less as compared to blade LASIK.
Yeah, you can adjust the age. I mean, that's age designing can be changed. Yeah, but even if ingrowth occurs, it is in LASIK, it is always easy to lift up a flap, but I don't know about the smile part. Yeah. How many times you can?
How long can we?
Just to complete it off for the general ophthalmologist, they might just have a question, after how many years of LASIK can you lift up the
I did after 22 years, 20 years, 25 years, throughout the life. There is a flap, plane once you reach the plane by just cutting in the side cut, it is easy to lift it up, nothing.
And just to complete off, ma'am had actually, I think ma'am what she wanted to ask was, which patients are ideal for microkeratome LASIK and for the flap LASIK, the femto LASIK?
Yeah, microkeratome, any age group. Flap LASIK, femto LASIK, I still believe it should be below 40. Not people can go 45. It's up to the surgeon, but I believe that better not to touch more than 40 years of age. The pressure part is the only tricky thing.
He didn't mind going for -17, -18, but the standard textbook, we find that you should not go for LASIK more than 10.
Power.
Sir,
it depends on the cornea. As I was, Divesha was telling that when it started in Sanjeevan, this better site, when I went there, so they had a different machine. So there, we used to do 17, 18 also. That time 250 micron thickness was left there and 17, 16 routinely. And touch wood, believe me sir, nothing has happened so far. Otherwise, we cannot carry on this long. But yes, but nowadays better to keep in a comfortable zone. But there are surgeons who are doing 12, 13 even, ablating 140, 150 microns of tissue. But I try to keep less than 110, 115 at the most.
No, I remember doing those -17, even 20 we had done. In those cases, what used to happen is that when the regression comes, it comes to somewhere -5 or -3 or 4.
Yeah.
Patients are happy because their power thick, odd looking glasses are taken off, just giving -3, -4.
And you have done it -5.
But better to nowadays better to keep below 11, 10, 11 maximum.
In the average textbook, good textbook, it is said that if it is beyond 10 or 11, it is better that you go for IPCL or ICL and then go for LASIK.
Only thing my take is if the patient learns to live with -1, 1.5. Why push for ICL?
No, I'm just asking. I'm just trying to increase my knowledge.
Yeah, because I don't think, yes, one can do, but the thing is, it's not a permanent solution.
Patient with more than 10 or yes, they have got a thinner
cornea. Those cases, yes, ICL is a choice. Even refractive lens exchange is a choice. That's up to them.
So, thank you, Dr. Chaudhary. Now we move on to the next topic, post-LASIK dry eye. So we have Dr. Arun Mohanto, who's a senior consultant, cataract and refractive services at the Disha Eye Hospitals, a prolific speaker, winner of many, many international awards, video awards. Just to name one or two, the Best of Show Video Awards at the American Academy of Ophthalmology, New Orleans in 2007, and the list goes on. Over to you, sir.
Thank you, Subhrangshu, and thank you, Chandramati and Kolkata Academy for giving me this opportunity. I'll be talking on post-LASIK dry eye. Don't get afraid, dry eye doesn't happen that commonly following LASIK. So, up to 95% of patients experience dry eye post-LASIK, but in most of the patients, it gets spontaneously resolved with putting drops within 3 to 6 months, and when the healing period is over. So these are the frequent symptoms patients complain of following LASIK, like dryness, foreign body sensation, burning, pain, itching, photophobia, and blurred vision. So now coming to the risk factors, the most significant risk factor is a pre-existing dry eye. So before going for LASIK, we must check the patient thoroughly for any existence of dry eye and treat the patient accordingly and then proceed. Long-term history of wearing contact lenses is another problem, because most of the patients who are coming for LASIK are using lenses for a long time, and so these are the patients in whom the dry eye can set in, and Asian races have been found in studies that they have high prevalence for post-LASIK dry eye. So there are some surgical risk factors as well, like superior hinge, and if we do a superior hinge, like Dr. Chaudhary was showing us, that if we do a superior hinge, the sectioning of the nerve fibers from the nasal and temporal subepithelial plexus gets injured, and the chances of dry eye is more in that case. If the flap is very large, and if we ablate a larger depth ablation with higher diopters, the chances of dry eye is more. So these are due to iatrogenic report, like evaporative dry eye due to meibomian gland disease is the most common reason for dry eye post-LASIK. Inadequate tear film integrity and function plays an important role in evaporative dry eye post-LASIK. The neurotrophic nature post-LASIK compromises the lacrimal function unit. Why neurotrophic? Because you are injuring the nerves, so the cornea somewhat becomes insensitive, and it compromises the lacrimal function unit, like the impulses that goes from the ocular surface to the brain and then to the lacrimal gland gets hampered, and reflex lacrimation is not there. A nasal hinge position triggers less LASIK-induced dry eye than a temporal hinge position. So while we are doing LASIK, we are injuring the nerves, so there is the impact of nerves which is causing that feedback loop mechanism to get compromised. The cornea becomes somewhat insensitive, and that feedback loop is again not there, so till the nerves get regenerated, there is some amount of relative corneal insensitivity which leads to dry eye. The goblet cells get injured, like we were discussing, like in case of blade LASIK, the microkeratum suction, it hardly takes 12-13 seconds, and in that case, my suction cup that is sitting on the limbus causes less goblet cell injury than femto LASIK, where the suction time is much more, not less than 45 seconds, 30 to 45 seconds. So it induces more goblet cell injury. The epithelium also sometimes get disturbed because of the microkeratum pus. The tear film osmolarity becomes hyperosmolar because the tear production is less, so the tear film tends to become more hyperosmolar, and the tear dynamics changes because the corneal shape changes from prolate to less prolate. So, and we often see iron deposition line in case of corneas post-LASIK. In hyperopic LASIK, we find a round ring like the keratoconus one, and in myopic LASIK, we get a central dot of iron pigment deposition in post-myopic LASIK. So the tear dynamics changes is also another reason for the dry eye to happen. So once the goblet cell loss is there is decreased mucin secretion and altered mucin expression on surface, loss of tear film stability, and there is dry eye. And you can see that the goblet cell injury rapidly corrects itself within a month. Dry eyes can substantially affect patients' perception of their surgery at the level of satisfaction and their level of satisfaction. Dry eye was the most common complaint during follow-up. So in order to optimize the corneal surface, we need to do a lot of preoperative evaluation like Sharma's test, TBUT, mammography, if you have the Blippi view thing, staining of the corneal surface and conjunctival surface, and ocular surface disease index. So the Sharma may be low, TBUT low, staining is positive, OSDI positive, there is systemic, there is aqueous deficiency dry eye disease. You need to grade the severity and proceed accordingly. TBUT low, clinical signs, staining, lead changes are there, mammography is negative, gland loss, and OSDI is positive, cause evaporative dry eye. Sharma's test low, TBUT low, staining plus minus, systemic plus minus, mixed dry eye disease, and there are symptoms and signs are very high, OSDI plus plus plus, corneal nerve and related changes there, so it's neuropathic dry eye disease. So in these instances, you need to grade the severity and proceed accordingly. If it's a mild dry eye disease and moderate dry eye disease, then treat the dry eye and proceed for the surgery. But if there is a severe dry eye disease and there is neuropathic dry eye disease, then avoid refractive surgery. So step 1 is to educate the patients, managing environmental causes, dietary modifications, ocular lubricants, lead hygiene and warm compress. And if step 1 fails, then preservative-free ocular lubricants, tea tree oil treatment, tear conservation, physical heating and expression of the meibomian glands, like intense pulse light therapy, and prescription drugs to manage dry eye disease. So topical cyclosporine A helps to improve TBUT and Sharma's test score after LASIK surgery, but there is one thing you must remember, like most of the cyclosporine is dissolved in castor oil, and this castor oil might go inside the flap and cause DLK. So that's another complication following LASIK, which is very tough to handle. So coming to role of hyaluronic acid based artificial tears, my choice is sodium hyaluronate, which is 0.15%, polyethylene glycol, propylene glycol, and HP-Guar polyquat combination. Sodium hyaluronate is a mucopolysaccharide, is a key component of the extracellular matrix, plays a critical role in cell proliferation, anti-inflammation, and wound repair, and has viscoelastic and hygroscopic properties. It has potential synergistic benefit of combining HP-Guar with hyaluronic acid. Hydroxypropyl guar is a mucomimetic gelable agent that binds to the damaged hydrophobic areas of the epithelial cells. Polyethylene glycol and propylene glycol then adds volume and restructures the tear film by forming a protective gel matrix. The high molecular weight of hydroxypropyl guar molecules along with natural mucin layer prolong retention of the demulcents on ocular surface, which provides sustained lubrication of the eye. This protects the ocular surface from further damage during the process of epithelial healing and remodeling. In addition, sorbitol, which serves to optimize the viscosity of the solution. Polyquat is a preservative used in this particular eye drop, and is a polyquaternarium or polyquat is a hydrophilic cationic polymer that was initially developed and used as an antimicrobial disinfectant in contact lens solutions. With more than 30 years of usage, safety concerns that were raised with polyquat are not there, is minimal. It does not adversely affect the ocular surface and has shown to offer comparable tolerability to a preservative-free eye drop. My experience with cystine hydration post-LASIK surgery patients regularly present with foreign body sensation, fluctuating dull ocular pain following in the post-op visits. I am routinely using cystine hydration in these cases. There is a significant improvement in the Sharma values, TBUT, staining patterns, and OSDI scores of these patients when compared to the routine artificial tears. Post-LASIK dry eye is common, and some patients may experience it for prolonged periods of time. Post-LASIK dry eye is an important reason for morbidity and poor patient satisfaction and surgical outcomes. The dry eye could be present before LASIK and may worsen post-LASIK. Diagnosis and management of pre- and post-LASIK dry eye is beneficial to improve the outcomes. Hyaluronic acid-based artificial tears not only improve symptoms, but also improve ocular surface parameters, thus are beneficial in pre- and post-LASIK dry eye. Thank you so much.
Thank you, sir. So, from a practical point of view, to assess the dry eye in a patient planning for refractive surgery, what are the tests that you routinely do?
We routinely do a Sharma test, and we obviously look at the tear film meniscus height, the tear film breakup time, and we have a lippy view to view the meibomian glands before proceeding. And in cases, doubtful cases, we do staining as well.
And routinely after a LASIK, how many, do you depend on the symptoms of the patient, or do you just, as a rule of the thumb, say that, lubricant should be continued for 6 months, or?
I usually prescribe lubricants for at least 3 to 6 months, and those who are IT professionals who work with long duration in front of computers, in them I tell them to use the lubricants as long as okay with it. Because if he discontinues the drop, the symptoms might come back and the dryness might set in. So it's his or her prerogative to use the lubricating drop as long as possible.
Sir, in the post-LASIK period, what is your take on the lubricants which work on the lipid layers as well? Any extra advantage that you might get, or because they are a little stickier, you might avoid?
I didn't prescribe any lubricating drop with the mineral oil added in post-LASIK patients, but with this thing with sodium hyaluronate I am very happy.
And your take on cyclosporine pre or post-op, any routine recommendations?
There are studies which prove that the corneal innervation thing is much faster if we use cyclosporine drops, and there are studies as well which says that the castor oil that is present in cyclosporine goes inside the interface and cause DLK. So that's again I don't use usually.
Routinely you do not use?
I don't use.
Yeah.
I'm not sure whether anyone uses here.
Any questions from the house?
Ayon, before Cystine came into the market, you were doing LASIK. What artificial teardrops you were using at that time when Cystine?
Carboxymethyl cellulose.
Pardon?
Carboxymethyl cellulose.
Oh, thank you.
So carboxymethyl cellulose, will it suffice after this LASIK?
No, because cystine hydration has a special, sodium hyaluronate has a special affinity to imbibe water, tear. So it almost 1 molecule of sodium hyaluronate can accumulate 30 molecules of water to wet the ocular surface. So that water wettability and the water binding capacity of sodium hyaluronate is very high compared to other chemicals.
Ayan, I'd like to know that what is your cutoff for the Sharmas pre-operative before LASIK, and somebody who has a low Sharmas, for how long would you give a tear substitute and then reassess?
I usually prescribe, if the Sharma value is less than 10, I usually prescribe an eye drop and for say 2 to 3 months and then ask to discontinue and then again measure the Sharma. So if it is consistently below 10, I usually avoid doing LASIK. Or if I at all have to do a LASIK, then I do with a punctal occlusion.
Okay. Thank you.
So any comments from the chairpersons?
Well, I think the problem of dry eyes is very important and should always be kept in mind when a patient is asking for LASIK. He should be very well examined for the dry eyes, pre-operative, post-operative, and for a long period, and carry on with the drops for a long period of time. Don't stop it in mid. So after 3 weeks or 4 weeks. Continue for at least 3 to 4 months. That's what I was doing when I was doing LASIK.
Yes, sir.
Just digressing a bit from the post-LASIK scenario, over contact lenses, which lubricants can be used?
Yeah, cystine hydration can be used.
And carboxymethyl cellulose?
Carboxymethyl cellulose, usually I don't use.
I just want to know.
Only other drop I have used over contact lens is hypromelose, gentle.
I mean, do take any extra precaution, because most of the people now are with computers, when screen time is more than 10 hours. Most of
I think Tuhin will be presenting in his presentation, because I usually prefer doing phakic IOLs in patients who are in front of computers for a long duration, because definitely today or tomorrow that dry eye is going to set in a big time. So in those patients, it's preferable to go for intraocular surgery than disturbed ocular surface. It's my personal opinion.
Oyo, I just want one question. You just said that those who have lower Sharmas, below 10, you do a punctal occlusion, and if you have to do it, you do a punctal occlusion and carry on with LASIK. Is that what you said? Have you actually studied how much it improves the punctal occlusion?
No, ma'am. I don't have any study or something, but
when you decide to do a punctal occlusion, carry on with LASIK.
punctal occlusion improves the corneal wettability, the Sharma's values, and all the other parameters which we are looking at before going LASIK. No, ma'am. No study as such. No study as such. But the Sharma values, the TBUT, the meniscus height, everything increases. So that's what.
In case of AP4, do you go for LASIK? This watering is more.
So I think we can go. Yes, it's a blessing in disguise. So you have to put less lubricating drops post-op. Yes, sir. It's a reflex lacrimation.
Okay, thank you very much, sir. So, yeah, we now move over to Dr. Tuhin Chaudhary. He will be speaking on ICL, what you need to know. So, Dr. Chaudhary passed his MBBS from the University of Kolkata, did his MS from Amritsar, Fellowship in Comprehensive Ophthalmology with special training in cornea from LV Prasad Eye Institute in Hyderabad. He was an adjunct faculty at LVPI as well. He did international fellowship in cornea and external diseases at Budapest in Hungary. Underwent training in corneal lamellar surgery under Professor Busin in Italy. Presently, he is a senior consultant in cataract, cornea, and refractive services at Disha Eye Hospitals, Barakpur and Kolkata. He's published numerous articles, has been a chief instructor in many courses, and performed live surgeries in many conferences. He is a recipient of many awards, including the prestigious Madan Gopal Oration Award on Cornea. Formerly, he was also the chairperson of East Zone of the prestigious Eye Bank Association of India. It will be a privilege to listening to you, sir.
Okay, good afternoon, everyone. At the outset, my sincere thanks to Dr. Chandrima Paul for the opportunity, and Dr. Mohanto, who just shared his slides on ICL. So I will be talking on ICL and what you all need to know. So what is ICL? That is implantable collamer lens made from collamer, that is a collagen copolymer, and proprietary belongs to Star Surgical. Collamer is a biocompatible, stable and flexible, that way it enables minimally invasive insertion in the eye. The EVO VCN ICL is a single piece foldable posterior chamber phakic IOL made of collamer. It has optic zone and then body or haptic and then foot plates. So optic zone is near about 6 to 6.6 and then it has a central hole, then these two peri-optic full thickness holes in the body or haptic, and then foot plates is having also full thickness holes, and that is for proper orientation in the eye. So what are the advantages of ICL? They do not require corneal tissue removal as like laser vision correction does. Additive procedures like removable, it can be, that means done in case of potential complications or in cases of patient's future needs, you can remove that lens. And they have been shown to provide better visual quality in some patients with fewer aberrations or dysphotopsias. Phakic IOLs also avoid potential side effects of laser vision corrections like dry eye. So excellent outcomes with ICL is achieved by a combination of preoperative assessment, efficient surgical technique, and postoperative evaluation. So available ranges like that EVO, VC and ICL, that is, it is available from -0.5 to -18, that is -0.5 to -3 in 0.25 diopter strips and -3 to -18 in 0.5 diopter strips. And EVO toric ICL, where we can get -0.5 to -18 with 0.5 to 6 diopter cylinders, and that is also available in 0.5 diopter strips. EVO plus ICL, where this optic diameter is a bit larger, around 7 millimeter, to avoid this glare. So EVO plus ICL is also having this -0.5 to -14 diopter and -0.5 to -3 in 0.25 strips and -3 to -14 in 0.5 diopter strips. And EVO plus toric ICL, it is also having, that means that 0.5 to 6 diopter cylinders in 0.5 diopter strips, you can get it. So then VC and ICL with hyperopic applications, that means this for the correction of or reduction of hyperopia ranging from +0.5 to +16 diopter and less than or equal to 6 diopter of astigmatism at the spectacle plane. So to set up for an ICL, you don't require just like a refractive setup, like laser correction machines, anything like that. Any cataract surgeon can do that with a good optical biometer, and an associated machine is must in these cases. So basic criteria is that minimum age should be 18 years and the refraction should be stable for at least 1 year. In the early history of phakic IOLs, the trend was to offer phakic IOL to patients who were not good candidates for laser vision correction. So now we consider phakic IOLs for patients with -8 diopter of myopia or more. And in patients with -4 to -7.5 diopter of myopia, we just discussed the phakic IOLs alongside the other refractive surgery techniques, ultimately selecting the procedure that is best for the individual patient. So below -4 diopter, we suggest LASIK or PRK procedure in these cases, no ICL in these cases. And ICL is the obvious choice, as mentioned, because of dry eye, for IT professionals in cases where this cornea is thin, and in these cases you have to check this percent tissue altered, that is, it should be, that means less than 40%, and residual stromal bed should be should be more than 300 microns. And in cases where there is suspicious topography, we should go for ICL. And if the patient had dry eye disease or if any epithelial dystrophies, in those cases we should go for ICL. As I mentioned earlier, that very low or high K readings. It was the question that in cases where we should go for this femtolasic, where should we go for microgratum LASIK. So in cases, if there is very low or high K readings, in these cases, if you go for LASIK, then better to go for femtolasic, not microgratum LASIK, because in these cases, there is flap complications are quite high. Now this percent tissue altered, that is this flap thickness plus ablation depth divided by central corneal thickness, and pre-op central corneal thickness should be 500 microns and residual stromal bed should be 280 microns. So contraindications like corneal or endothelial pathology like Fuchs endothelial corneal dystrophy, pre-existing glaucoma, narrow anterior chamber angle. If the patient had some sort of this anterior subcapsular cataract or any sort of anterior cortical cataract, or if there is subluxation, we should avoid it. So basic investigations, as like in this LASIK procedures, cycloplegic refractions, biometry, optos, white to white measurements should be done. Now this internal anterior chamber depth should be 2.8 millimeter or more. So internal chamber depth is the depth between the distance from this endothelium to the anterior surface of the crystalline lens. So in normal biometer, that this anterior chamber depth is usually more, because that is taken that is that means that here we have added this corneal thickness. So in that cases, what it is written there, this anterior chamber depth is 3.38, and then you have to reduce this central corneal thickness measurement, that is 530, that is 0.53, then 2.85 should be the anterior chamber depth. In pentacam, this is written already that internal depth, that should be like that AC depth internal, that is 3.3 millimeter. Now this white to white measurement should be the most important thing, and we can use it with calipers or topography. And sulcus to sulcus measurement, which is done usually by ultrasound by microscope, that is the best way to do it. And angle to angle, that can be done by, that means this OCT machines. So now what we are using this digital caliper. So white to white, that is this inaccurate values may lead to inadequate sized ICL, too small or too large, which in turn may lead to adverse reactions. Anatomical differences and irregularities as well as individual patient features may lead to unexpected adverse events related to adequate sizing. So white to white diameter, that means that in biometry what we are getting and what we are getting from these calipers is totally different. So here we can see that this was written that about 11.7, and what we are getting is this near about 10.65. So there is some confusion also in cases of posterior embryoprotections. So what we are taking it from this internal this area, but we should take it from the outer side. So this is the video how to go for this white to white measurement, and we have to take it thrice and then take the mean value. As I mentioned that in all these cases we should go for dilated fundus examination. So in this patient he had already this subluxated lens, which was diagnosed during only perioperative. We could see that patient. So lens design, that this posterior view of the myopic ICL model, that is this is the lens, anterior surface of the crystalline lens, this is the ICL, and this posterior vault. And posterior shape of the vault should be always important, and it can be measured by this anterior segmentosity. It should be around 250 to 750 microns. Here in anterior segmentosity we can see it near about 497 micron. So this post-op vaults, if it is that means too small or too large, we can see it. So ideal vault, as I mentioned, that 250 to 750 microns, or half corneal thickness to 1.5 corneal thickness. So oversized vault, that is high vault. So you can see that high vault. So there is there is chance that this patient may develop this angle closure. And low vault, you can see that this is touching this anterior surface of the lens. So there is chance that this patient may have anterior subcapsular opacification. So earlier days, we usually go for this peripheral iridotomies that should be done at least 1 to 2 weeks earlier, 2 peripheral iridotomies. Nowadays, it is not required because that in ICL we are having now these holes. So now refraction and then CCT is most important. This patient had this -8 with -1 diopter cylinder, but pachymetry was 502 micron. Because thin pachy, so here the good choice is ICL. Same way, this patient had this, as an IT professional, spent 16 hours in front of the computer. Even though pachy was quite good, still I did this ICL. Extremely thin cornea, the cutoff point is near about 480. So in this case, this patient had thin cornea, 446 microns, so we have to go for ICL. So then this lens power is put, and then we order the lens, and then this lens is delivered by the Star Surgical people, and then ready to go for implantation. And after implanting, check the first time before, after implantation, and then wait, see this vault, and then plan for second eye surgery. Now I have to go for perfecting intraoperative steps. That is the most important thing. So this is the setup where this HPMC or Hilon, whatever you take. This is this BSS saline. This is this foam plunger. This is the injector. This is the ICL forceps, and this is the cartridge, and this is the ICL container. So now loading of the ICL, that is the most important thing. Open the cartridge and fill with BSS and HPMC. For the beginners, HPMC is better because there is free flow. Here if you use this, this is this external view, and here in this case you have to use this HPMC initially. If you use this Hilon, then it may be that not having that much smooth flow. So open the ICL container and take out the ICL with foam tipping plunger and place the ICL edge at the edge of the cartridge. So here I am showing both ways, this microscopic view and external view. This is external view. And place one ICL edge at the edge of the cartridge, and then by slight rolling movement, push and rotate to put the lens inside the inside, so that the both flanges of the cartridge, that means be accommodated. You can see it. And now you can see that the three holes are properly placed, and then pull the ICL towards the tip, keeping the whole three holes in a straight line. And here we should be very careful that this should be very gentle, and load the cartridge in the injector and fill the space with HPMC to avoid any sort of air bubbles. Lock the cartridge in position, and now it is ready for injection. Now after locking it, you put it inside the bottles, otherwise it may just come out of the injector. So free flow now. Now lens implantation instruments, same like just cataract setup, just like this side port, paracentesis knife, then this microkeratome or this keratome, forceps, all those things. Surgical techniques. So many surgeons first initially they do go for 2 paracentesis cut, or you can go for temporal clear corneal incisions. It should be 2.8, and then you can make it 3 or 3.2. Then put these viscular sticks, and you can see that the chain of the viscular sticks can be visible. It should not be overfilled. Then injection of this ICL. Now you should see that the leading haptic should be towards the right side. Okay, then that way that it indicates that it is properly oriented. Then put another inject of just few cc of viscular sticks over the ICL, and then positioning of the ICL, that means behind the iris, and then you just aspirate the always never touch this optics, and then just remove this viscular sticks. Then you can constitute the pupil by using intracameral pilocarpine, and then just hydrate the wounds. It should not be too much over tight. And then you have to check this intraocular pressure after 2 to 4 hours. So this is another video where the surgeon initially put this side port. So they first put it one in that means near about 7 o'clock, another it in the 11 o'clock. But for us, 10 o'clock and 7 o'clock is quite enough for us. So this is from outside, that is this for better placement of this dialers. So he put this side port cards here one and another in here. But we can put it here as well as here. So now this is another video. So there is a lot of air bubbles. So while we are loading this ICL, you should avoid that air bubbles should be minimum or not at all. So sometimes these air bubbles may block your view of that hole in the foot plate. Now this is a case where we have to go for toric ICL. So in toric ICL, after putting the lens, it's difficult to align and rotate and manipulate the phakic lens inside the posterior chamber of the eye. So you have to rotate that lens just enter to the iris. And then you have to properly orient the axis of the ICL, and then you would tuck that haptic foot plates behind the iris. So you should not place this lens and then rotate it. You should never do that. First you have to align the ICL, and then you place the haptics, put the foot plates behind the iris. Yes, always put over the iris. Never try to put it behind the iris. Then you will injure the lens. After that, you have to put some viscoelastics, and then you place that means foot plates behind the iris. If for toric lenses, you have to align that axis over the iris. If you try to put the ICL behind the iris and then try to rotate it, then you will injure the lens. Juniors also. Now, that means that it was this keratome should be 2.8, even though they have mentioned that 2.2. That sometimes 2.2 or 2.8 or 3.2. That after putting this keratome, sometimes you have to just give some side cut. This was the patient where it was put, and and here you have to go inside. There is no wound assisted delivery, unlike your ICL. So you have to go inside. Here it was just wound assisted delivery, and then it was got stuck. So it was not getting folded. Then you have to put some more viscoelastics and then fold it. What I mentioned, that stuck ICL, that here this was just 2.8. I didn't do this that side cut, and I tried to go for this wound assisted delivery. Now it got stuck in the wound. See now. Okay. Thank you for your time now.
Thank you, Dr. Chaudhary. That was very nicely covered, the topic of ICL, choosing the patient as well as the operative procedure. So, like you were talking about high vault and low vault. So, in a case of a high vault and a low vault, how do you manage? How much time do you wait? What are the steps that you take?
Usually you can see that patient, and if the patient, if it is, that means patient, if it is not toric ICL, usually it will be stable, and you wait for at least 2 weeks. And if the patient is quite happy, there is no so much problems, then you can wait and ask the patients. Many patients with some minimum, that means for low volt, you have to remove the lens, because it will definitely cause, that means that this cataract formation.
So, for example, a 150 micron vault on, say, day 7, you wait for some time, or?
No, you have to take it out.
On day 7, if it's less than 250, you have to change. So basically, you would expect a problem with the sizing, I mean, with the white to white and other measurements. So, for white to white values, I presume you mainly depend on the calipers only.
Yes, that is.
Calipers itself, yeah. And second is, post-operatively medicines, what regime do you follow in LASIK cases, in ICL cases?
In ICL cases, just like the cataract, whatever we follow for cataract, but here we just give those this pre-acetate eye drop, not 6 times, only 4 times, and only for 4 weeks.
For 4 weeks, for a month. And in post-LASIK cases?
Post-LASIK cases, we never give pre-acetate, we just usually give fluorometholone 4 times per 1 week, then 2 times per 1 week, then stop it.
And in PRK?
In PRK, in PRK, after taking out this bandage contact lenses, after 3 days, we start pre-acetate eye drop for 4 weeks, 4 times initial 1 week, then 3 times, 2 times, one time, 1 week tapering dose.
Do you do IBM, UBM?
UBM should be the ideal way to measure this,
where the haptics are placed. To see the, have you seen those?
No, for us, post-operative cases, we don't do that much. But only ASOCT, that vault measurements is enough.
If the myopia is very high, the diameter will be high. So in that case, the ICL size will be also different size you have.
You get it.
What about the post-operative astigmatism, especially in toric IOL? You are making 3 incisions. Right? So what about the post-operative astigmatism?
Usually 0.5 to 0.25. The patients are quite happy about that, because that here there is no question of surgical induced astigmatism, all those things. So 0.25 to 0.5. That is
basically that the one you are telling, that post-operative astigmatism, they already calculate and put this there in the software that you are going to put this amount of incision and these 2 side ports. And that is there in the algorithm during calculation, and accordingly they will send you the lens.
Okay. And
for me, I usually put, but many surgeons don't put it. I put it.
I don't put pilocarpine because it causes a lot of pigment dispersion, and that doesn't look good. I mean, it all settles on the lens.
what is the minimum?
What about the intraocular pressure fluctuations before and after surgery? And do you do routinely a peripheral iridectomy, or?
No, nowadays I don't go for iridectomy. Usually on first initial 2 days, usually give tablet acetazolamide 250 milligram 2 times daily for 2 days only. And usually we don't have that much because that's post-operative IOP hike. But because that we cannot remove that these viscoelastics properly, thoroughly, so that's why we just, to be in safer side, we just give it.
But that problem is not there if you are using sodium hyaluronate. So the whole thing comes out as a blob, so there is no leftover viscoelastic inside the antechamber. So
that's the thing.
Anterior chamber depth, minimum anterior chamber depth you should consider before
2.8 millimeter.
2.8.
And
IPCL, I have used only 2 or 3 cases, but recently there was some report of this test, so I have not used so far after that. But many of our colleagues in hospital, they are using it now again.
My routine regimen is, if the patient can afford, I go for ICL. If it cannot afford, then I go for IPCL, or there is another phakic IOL, that's acryl phakic IOL. So in case of IPCL, it's my personal opinion that I have used more than 100 IPCLs and placed them horizontally and saw them after a month or 2 months, found most of them rotated to some extent from its horizontal position. So rotational stability of IPCL is doubtful. Whereas acryl phakic IOL by Biotech, that is rotationally quite stable. For patients who cannot afford ICL, toric, go for acryl phakic, and non-toric, I go for IPCL. The size is, I mean, there are the fixed sizes, like 12.1, 12.6, like that, millimeter. The design.
So, wonderful presentation, Tuhin. Just going a step further. So, IPCL or ICL has been in vogue for quite some time now. So, we do get to see patients who've come with cataract now, post ICL, yes. So, a couple of questions. Number one is that when a patient comes to you with cataract following a ICL, the biometry that you do, the modern machines, like say, we have the IOL Master 700 that has particular modes where you can actually put it as pseudophakic and also anterior chamber IOL and get it done. But where those machines are not there, supposing a IOL Master 700 is not available with somebody, then how do they go about the biometry to explant the lens and then implant? That's my first question. And my second question is, when a patient comes to you with the anterior chamber ICL, so there actually how also you go about the biometry, and on the table, would you first, because there you can't dilate the pupil first, you first got to explant the lens, then you've got to dilate the pupil, then do your phacosurgery, and then implant another lens. And there, would you keep a standby of 5 lenses like we do for refractive surgery and do a refraction on the table in the theater before you implant the lens? So these are the two questions.
What thing is that in both the cases, what we do that, we just take out explant the ICL, then do this cataract surgery. Then we send the patient for refraction. And then that refraction, as per the refraction, we just put the IOL.
So you do a 2-step procedure, like 2 days?
No, on the same day.
Basically, modern day biometers, most of them, optical biometry that doesn't
you don't have an IOL master, say.
Not even IOL master. Any optical biometer will give accurate result. Yes.
Cataract surgeries. And I think normal biometry readings were absolutely fine.
Absolutely fine.
We did not need any IOL masters. Nothing. It's a biometry reading remains the same.
And do you reconfirm that on the theater table?
I did not, and I did not have any.
No standby of lenses.
No. There's no need.
Okay.
There's no need.
Okay.
Yeah, absolutely. Because see, in optical biometry, it doesn't matter at all. In case of ultrasound, it might, to some extent, lower down the sound that is going in, giving inaccurate result. But that too is a very minimum. I mean, I don't think it's going to cause a hell of a difference. Maybe a 0.5 max.
Not at all. Same.
Phakic IOL actually will be sitting, so the anterior chamber depth will remain the same. It is in the chamber itself, so the thickness doesn't change. That is why the vaulting becomes important. So when we are taking the biometry, because it will depend on the depth, which is almost same, whether we have the ICL or don't have the ICL, there won't be much of a difference in the IOL power calculation.
Yeah, definitely, sir. But in case of optical, it will not matter at all. In case of ultrasound biometry, there may be a 0.25 ki 0.5 difference, that's all. I mean, if at all, I'm not sure. Because that's so thin, that is not going to impede the sound that is going in.
Just 90 micron, the ICL.
50 micron in the center.
50 in the center.
And if you are lucky, then it will go through the hole.
So the one question I want to ask, Sir Ayan sir, Devesh sir, when we are doing the ICL, what sir said, volt of less than 250. I have a patient I've been following up for the last.
Follow up, no problem.
Yeah, so do you really need to explant
I
it?
have vaults even less than that. I have 50 microns, 75 microns vault also, and I am observing them, nothing happens.
Right.
But there is sometimes a peripheral touch. You're looking at the center, but there is a peripheral touch sometimes. In that case, you have to remove. If there is a peripheral touch, dilate fully, look at the vault from top to bottom, and then decide to remove or not. If there is a thin gap all throughout, there is no need to remove.
And UBM?
And you tell after 1 month or 2 months, you have cataract, you have to do cataract. I will counsel the patient.
Usually it doesn't happen. Usually it doesn't happen. I mean, hasn't happened yet. Only my first patient, if you can show the picture, if you have it. In that
was
case,
also after 20 years, we believe.
Yeah,
he did that case in 2008, I believe.
2007.
Hey, 2007.
My first ICL patient. That patient I had given you the photo. In that case, there was 2 PIs done, mid-peripheral. At that time, we had very less experience, and the PI are awfully looking, and see. And this patient had developed anterior cortical cataract. OCT? Yeah, you can see that anterior cortical cataract. That is because of the PI and not because of the ICL touch.
One question.
Yeah, PI, because the PI was mid-peripheral and it hit the lens in the mid-peripheral region and it has progressed to the center.
Do you face any iris changes, this like iris atrophy or anything after ICL?
Only point, I mean, he has missed out, I think, if there is an ICL flip. While implanting, if there is a flip, what will you do? In that case, it's better to remove it and again re-implant. Better not to, flip
Do
it
into inside the eye.
Flip it again inside the eye. You can do, but it's a very risky proposition.
Hearing of the lenses.
I believe everybody who started, my first case, there was a lens touch. Generally, sir, because you all will have more of experience, that touch, the patient doesn't have too much of a problem. I am observing the patient, there is a cataract which is there, but till the time the patient doesn't have any symptoms, we don't even need to go ahead and do the cataract surgery.
Yes, absolutely.
Even
and one more thing I would like to tell that, like Tuhin showed a picture in which you need to see the first eye before going for the second eye. And if it is a spherical ICL, we all know that the horizontal sulcus is less than the vertical sulcus. So if there is a high vault in the first eye, you can put the lens in vertical position, it will take care of the vault by 200 to 250 microns. If suppose the patient in the right eye has a vault of say 800 microns, if you put the lens instead of horizontal, if you put it vertically, this vault is going to be something close to 550 to 600. So that way you can take care of the vault if it is very high on the other eye.
And in that case, you have to put a superior incision.
So I am using here sodium hyaluronate for a long time. Yeah, it comes out as it is. It's not a problem at all. But if it is methyl cellulose, some amount of methyl cellulose is definitely going to remain behind the ICL. You cannot remove it. And if you try to remove, then you are going to injure the lens or injure the crystalline lens, anything. Either of these two. If you are doing both eye cataract surgery in a single day, yeah.
So just going back a bit, since we have such a knowledgeable panel with us. So in going back to LASIK, epithelial ingrowth, what is the standard management protocol that you follow, Sudeep sir? Thank you, Dr. Chaudhary.
I think very less amount of ingrowth, almost not negligible in the borders or margins can be watched for, but it is significant, gives symptoms, or the astigmatism, the cylindrical power keeps changing, it changes, then we'll have to lift up and just scrape it both. And after scraping, cleaning the bed and all, better to put a contact lens over it to seal the wound, edge of the wound. That is very important. Mitomycin, I'm really never used it in otherwise, but I did 3 epithelial ingrowths, one from a patient from Bangladesh, so that's a bad ingrowth, but after scraping and just doing everything, cleaning properly, washing and put a contact lens, it is quite stable.
And what I have learned from Dr. Chaudhary in my initial days is that do the procedure really fast. The more you dilly-dally, the more you keep cleaning the bed, the more you keep ironing the flap, the more probably the chances of epithelial ingrowth. So just do it fast. He does it really fast. I have seen others also. So that is one thing. Second is from my own, I had a problem of, I was doing a femto LASIK and then patient was not cooperative, moved her eyes, and then I had to redock, then abort the procedure itself. So there are some specific guidelines, and I request Dr. Mohanto to kindly.
I'm not conversant with SMILE. Femtolasic, yeah. So if there is a suction loss, what I do usually is I redock the patient in the same position, taking a slightly bigger flap diameter. So same day, same sitting. So that takes care. Yeah, I again redock and do the thing. Same.
Basically, what sir says, it just depends on which stage you have the loss. If it is a little bit less than 30-40%, whatever, then I think just redock and do it. I did it, one case I did it in the same depth, and with a little less margin. And if it happens, and then what happens is the first step is a pocket, then the bed, last the recut. If the pocket and bed is partly done, then you, in the second cut, you leave the pocket. You just go for the recut and the side cut. The bed and the side cut, not the pocket anymore. And in case it is a side cut problem, then just go for the side cut. This has there are options there. Only go for the side cut with a smaller diameter.
Any case where you had to actually do it after a couple of weeks at a different...
No, touch wood, not so far.
So, any comments from the chairpersons?
Well, I will tell you the story how I came into the LASIK business. It was sometime in 1996, October, November. A young lady around 30-35 years old had come with irritation in the eye. And when I saw her in the slit lamp, I said, you just have a dry eye, so take this prescription. She pointed to me, doctor, you have not seen my eyes properly. I said, what? No, you haven't seen my eye properly. It's not just the dry eyes and irritation. I had a surgery. I said, what surgery you had? I couldn't see anything. No. I said, okay, come, let's sit back again in the slit lamp. And then I saw, she said to me, I had a LASIK surgery in Germany, sometime 2 years back. So I put her back on the slit lamp and I saw this very fine cut, the flap. And before that, I hadn't seen any LASIK because at that time the LASIK was not there in Calcutta. I'd never seen a flap in the LASIK. And when she showed me that, it was wonderful. Well, I was 4.5 and now I'm 0 power. And I'm very happy, except for the dry eyes and irritation all the time. So I said, this is the surgery I want to learn. And that very day, at that time, Partho, this was in sometime 1996, Partho was doing PRK in Better Sight Center at that time. And then I said, I will go there. I went there, they didn't have the microkeratome. I bought a microkeratome, and then we started, me and Partho started doing cuts on the goat side. And after 10 o'clock, after finishing our chambers, we would go to the better side, open the gates, go in, do everything, lighting, everything, and then we would play with the microkeratome, which I had bought very new. And that microkeratome was a SRK microkeratome. And we didn't touch a human eye till we could get 2 consecutive days of 100%, 100 out of 100 eyes without complications of the flaps. Then we started the LASIK in sometime in 1997 January. So that's how we got into LASIK. And can anybody tell me who discovered the excimer laser? Huh? Any idea? You're right. Moni Bhomik in 1973 first time showed that excimer laser has the ability to cut biological tissues, specific area, without damaging the side areas at all. And then Palikaris, Ioannis Palikaris of Crete, in Greek, a small Greek island in the Mediterranean Sea, Crete, in Harlikion, in the University of Crete, he was testing this laser for some army laboratory. And then he said, if this can happen and it is good for biological things, he started doing PRK first, and then there are a lot of complications of PRK in the sense of pain, and you have to put the pad and all that. So he made the microkeratome and did the LASIK for the first time in 1989. Fortunately, I had a luck. I went to Palikaris, sir, in 2000 in January, and I saw him operated in a lab. I was there for 10 days. And there also I saw for the first time the ICL and lenses being put in. And he used to routinely put pilocarpine and do a small peripheral iris. That was it. That's how I came into this refractive surgery business. Because it was so fine, the lady changed my mind. Unfortunately, it so happened that I was there doing LASIK till the year 2002, 2003, when our LASIK machine, Sudeep knows, he had just come, and it was giving erratic results. I remember a patient with -3 I had done. After 2 months, he comes back to -2.5. The regression, because the laser was not working. And I thought, oh my God, this is happening with this machine. I told Ravi Makharia, who was the owner of the better side, we change the machine here, do something to this. This is not done. Well, sir, kahan se paisa aayega itna sara and all that. So I said, bhai, I'm nahi karega. Partho went on and Sudeep went on and I left. That was the end of it. After that, the Himalayas brought the laser. They asked me to come and do it. I said, no, I have left Ravi. If I do at your place, it would be nice, so I gave it up. They continued and they are there now. Okay, that's my short story of getting into refractive surgery.
First mission or the first? That was the initial one, yes, yes. But they got the technolas and then it keeps changing. Yeah, but those were really difficult time. But we had no option. We had to do. Better Side have sold their machine. Implant Better Side, they have sold the machine. They stopped. He told that it's. Oh, that Ravi is still in that business, yes. Daman. No, in that he sold that thing to Implant House. Yeah.
So we can just a small video we'll show. This is flipping the ICL within the anterior chamber itself. So, and after that we'll have concluding remarks from the office bearers of the KAO, and then we can disperse for lunch. For those young people who are here, the feel of the ICL, when I first did my ICL, the feel was so different. We have all dealt with IOLs. This is such a thin thing that the first time you're touching, you really feel, I mean, it's little different. But once you move on to your third or fourth case, things actually get much smoother. So, yeah, we are ready with the video.
So this is a case, one of our consultants who is doing LASIK, just started doing LASIK. So one eye went well, this is the other eye. So while putting the lens in, it got flipped. And then I did an opening over here, filled the chamber with viscoelastic adequately, and tried to fit the edge of the ICL in this forceps. It's a difficult thing, but if you do it like this, you are not going to injure the lens. Yeah. Now it's, yes. So that's it. I think I don't have that video. Let me see. See, just fill it onto the forceps. It took some time. Yeah. Heel on. And then just flip it. Because we used to reposition dissect disc in this manner. So I had suddenly got, I can do it like this, so I just tried and it went well. That will not cause anything, because normally the lens opens like that. It grazes on the lens anterior capsule and then opens up. Yes. And the material is quite tough. It's very difficult to tear the material while pulling it out. Until you are pulling, if you are not pulling with a tooth forceps, then it's a different issue, but normally it is very tough.
The anterior cortical. So that was a very lively session. Can we have concluding remarks from the secretary of the KAO, please?
So first of all, thank you, Subrangshu, for conducting this program so well, so seamlessly, and sailing through so smoothly. Thanks to our esteemed chairpersons and our respected panelists, and to the speakers for sharing their knowledge, and to all the audience who took all the trouble to come here and stay with us till the end. Thanks to Alcon Laboratories India for sponsoring the program. Thanks to the JW Marriott staffs for their nice cooperation. We really felt it good, and hope to see you in future with such edition of yet another edition of this program, series of programs. And last but not the least, thank God Almighty for giving us the strength to come back to you each and every time we face trouble. So thanks. Till we meet again, let's break for the lunch. Thank you once again. Please note that the forms for memberships are available with Dr. Shomyadi. Whoever is interested, please come and you can take the membership for the PZs as per declaration. Thank you.